So the NICE guidelines, which are in draft form at the moment, set out to describe how we should diagnose and manage abdominal aortic aneurysms. I suppose the controversial aspects amongst much advice were that the first thing that's the standout problem with them, as many people see, is that no elective patient in the UK should have EVAR at all ever. And then that any patient who is unfit for an open approach should have no treatment. They should be managed conservatively. And those two aspects have the concept to actually change the landscape of how aortic repair is done in the UK and in other countries which look at NICE guidelines. There were some other slightly controversial points as well, including that surveillance should be CT based rather than ultrasound. And this has come just at a time where we are beginning to realize some of the negative aspects of CT-based surveillance, including a risk of cancer long term. And controversially again, they suggested that for emergency cases with rupture, EVAR should be done. And it's hard to see how that is possible if people are losing experience with the easier elective cases and then in an emergent situation have to do sometimes the more difficult cases which are not being done on a regular basis. I don't think so, because one of the difficulties now that the NICE committee has seen is that even if there was some form of acceptance, the physician body doesn't think it could actually implement these. And one of the big things around this, I suppose, is that NICE often rule on new developments, new technologies, new drugs, where practice isn't yet established. This is unprecedented to take technology which is probably 20 years and very mature in the landscape of aortic repair and say that it can't be done anymore. And that is probably unprecedented in their advice. And during the consultation process, there was an unprecedented response to this, mostly negative.